Okay, today we are going to discuss non-steroidal anti-inflammatory drugs. Actually, these are the analgesics like paracetamol, ibuprofen, aspirin. All of these are the non-steroidal anti-inflammatory drugs and we call them analgesics. Basically, I should go for this scheme for prostaglandin biosynthesis and with inhibitors. This is very important flowchart because we deal with analgesic drugs according to this. Whenever there's a stimulus, this stimulus can be cold temperature trauma to the skin. There is a disturbance of cell membrane. Phospholipids are liberated. These phospholipids, they are converted into arachidonic acid, and then arachidonic acid, it goes through two pathways. One we call lipooxygenase pathway, and the other we call cyclooxygenase pathway. The lipooxygenase, it forms hyperperoxides, and these hydroperoxides are converted into leukotrienes. Now, basically, hydroperoxides and leukotrienes are responsible for, and these are mediators of inflammation. Arachidonic acid is converted into prostaglandins, PG2, PGH2, and then you can see a series of other mediators. They are formed like prostacyclines, thromboxane A2, PGD2, PG2 alpha, and PGE2. All these are prostaglandins, except this. This is thromboxane A2. However, there are certain drugs that inhibit these pathways. Like here you see phospholipase A2. A2 helps in conversion of phospholipids to arachidonic acid. However, corticosteroids, they inhibit phospholipase 2. And similarly, there are certain drugs that inhibit cyclooxygenase enzyme like aspirin and NSAIDs. So this schematic diagram is important because of the fact that the mechanism of action for analgesic drugs that we are going to study in detail depends upon this diagram. Prostanoids, prostaglandins, and thromboxane A2 or thromboxanes. PGI2, we call it prostacycline. It is located predominantly in vascular endothelium. Main effects are vasodilatation and inhibition of platelet aggregation. Thromboxane A2 is found within the platelets, and main effects are platelet aggregation and vasoconstriction. What PGE2 causes? It causes inhibition of gastric acid secretions. It initiates contractions of pregnant uterus, so it helps in delivery, like full-term pregnancy. PGE2 helps in expulsion of the baby through contraction of the pregnant uterine muscles, and also contraction of GIT, smooth muscles. PG2 alpha, it has got main effects on bronchi. So it causes contraction of the bronchi and also contraction of the myometrium, that is the muscles. Now, what is the classification? Classification is actually we divide them according to effect-based classification, that what is the main effect of these drugs. Like the drugs with analgesic and marked anti-inflammatory effects, these are known as salicylic acid derivatives. Aspirin is the prototype drug within this group, and we also call it acetyl salicylic acid. And then we have salicylic acid, sodium salicylate, methyl salicylate, and so on and so forth. Then we have pyrazolone derivatives. Among the pyrazolone derivatives, the commonly used phenylbutozones are there as a propazone, oxyphenbutazone, sulfenpyrazone, and dipyrone. Then we have got acetic acid derivatives. Among the acetic acid derivatives, we have a lot, but the most commonly used among them is diclofenac and indomethacin. Others are sulindac, etodolac, and tolmethine. Oxycams, now these are the newer drugs and we are using them a lot these days. Among them are piroxicam, tanoxicam, and meloxicam. Drugs with analgesic and moderate anti-inflammatory effect, these are propionic acid derivatives, and you all know this brufen, ibuprofen. So it has got a lot of other drugs resembling brufen, like phenoprofen, ketoprofen, flurbiprofen, indoprofen, carprofen, naproxen. This is, about naproxen. commonly being used along with ibuprofen and also ketoprofen and phenoprofen, and then oxyprozine. Then we have got phenamic acid derivatives, and these phenamic derivatives, they are also known as phenamates. Mefenamic acid, fluphenamic acid, meclofenamic acid, and tolfenamic acid. Drugs with analgesic and weak anti-inflammatory effects. These are aniline derivatives, and the most important derivative within them is paracetamol. We call it acetaminophen as well. Now, the other classification is based on selectivity. Like some of the drugs will be COX-1 inhibitors. Selectively, they act on COX-1 enzymes. The other group of drugs, they will act upon COX-2 only. They will be selective only for COX-2. However, there can be mixed, also we have mixed action of drugs on both enzymes like COX-1 and COX-2, so they are not selective. So these drugs, they are commonly being used nowadays, like COX-2 selective inhibitors is celecoxib, velticoxib, and rofecoxib. These are the newer drugs. Non-selective inhibitors, as we mentioned, they inhibit both COX-1 and COX-2 and includes all the groups of the drugs. COX-3 inhibitors is paracetamol. Mainly, this is the only drug that inhibits COX-3. Now, what is a Cox enzyme? As we mentioned before, that we have COX-1, we have COX-2, and COX-3. Now, basically, COX-1 is constitutive enzyme, like it is building up the tissues. So mostly the tissues that include this enzyme, they are blood, platelets, and GIT. It serves as a housekeeping functions like cytoprotective of gastric epithelium. Like it makes a protective sheath or a covering over the gastric epithelium. So this makes it as a protective enzyme. COX-2 is induced in the cells when they are stimulated. That means it is secreted within the cells whenever these cells are stimulated and is responsible for production of prostanoids that are mediators of inflammation. Glucocorticoids, they inhibit phospholipase A2. Also, so that definitely when phospholipase A2 will be inhibited, it will also inhibit expression of COX-2, but not of COX-1. So here you can see that glucocorticoids, they are concerned and they are inhibiting COX-2, not COX-1. COX-3 sufficiently similar to COX-1. The COX-3 enzyme is without inflammatory actions and it is mainly found in CNS. Now, aspirin. Aspirin is prototype of traditional NSAIDs. That means it's a prototype drug, very commonly used drug. It is derived from a willow bark and its leaves. And it is when it was derived in past years, like in 1853, it was derived from this willow bark and its leaves. In that, it was derived in the form of salicine, which is known as glucosides. It is also known as acetyl salicylic acid because of its structure, and basically it is an organic acid because of the attachment of these COH and double O oxygen CCH3. So this makes its structure more organic. So that's why we call paracetamol as organic acid. Now, what are the pharmacokinetics and metabolism of aspirin? Aspirin, basically, it is rapidly absorbed through stomach, and as we discussed earlier, that it is best absorbed within the acidic medium of stomach because it is acidic. And small intestine, it can also be absorbed through rectal mucosa. It can cross the blood-brain barrier and placenta. It is hydrolyzed to salicylates and acetic acid by esterases in tissues and blood. Salicylate is metabolized in liver into salicuric acid, which is a glycine conjugate basically, glucuronoid conjugates, and salicylate. So these are the three basic metabolites that are formed. Salicylates, however, they are oxidized to gentisic acid, and this gentisic acid is conjugated in liver and then it is cleared by kidneys. When dose is small, like 600 mg DDS, means 3 times daily, there is a first order kinetics and half-life is 3 to 5 hours. However, when the dose is large, there is a zero order kinetics and half-life becomes 12 to 16 hours, and then there is excretion. Now you all know about plasma half-life. So though I'm not going to go into the details for the first order kinetics and zero order kinetics. However, one thing I should clarify that those drugs that undergo more zero order kinetics, then they are more becoming more toxic. So that's why if the drugs, they are more going through first order kinetics, they are more safer. So you can go through your lecture for plasma half-life. 25% excreted unchanged and 75% as metabolite in urine, and this is further enhanced by alkalinization of urine. That means that if urine is more alkaline, so it will be excreted more through urine, like 75% will be excreted in the form of metabolites and 25% will be excreted in the unchanged form. What is the mechanism of action of aspirin? Aspirin and NSAIDs inhibits biosynthesis of prostaglandins by inactivating Cox enzymes. Aspirin is non-selective Cox inhibitor, causes acetylation of COX-1 and COX-2, thus irreversibly inhibits cyclooxygenase activity, while most of the NSAIDs act as reversible competitive inhibitors of COX activity. That means their inhibition can be reversed. However, in case of aspirin, it is non-selective. That means it can act both on COX-1 and COX-2. And what causes the irreversible inhibition? That it causes acetylation. Acetyl groups gets attached with the cyclooxygenase enzyme, and thus this attachment or formation of a bond between acetyl group and cyclooxygenase inhibits cyclooxygenase activity irreversibly. Various NSAIDs have additional mechanism of action, including inhibition of chemotaxis. This is, you all know, migration of the white blood cells and macrophages, decrease pro-inflammatory cytokines like TNF-alpha and interleukin-1. This TNF-alpha is tissue necrotic factors. Pro-inflammatory cytokines are those that are liberated before inflammation occurs, like they are going to cause inflammation, but before completion of the process of inflammation, they are liberated. Decrease production of free radicals and superoxides, induce apoptosis. Apoptosis is programmed cell death, and it can also interfere calcium-mediated intracellular events. Now, this is a schematic diagram showing the mechanism of action of corticosteroids and NSAIDs, and it's very much obvious that whenever membrane phospholipids, they are interrupted by any trauma, damage, what happens? Arachidonic acid is liberated. This arachidonic acid goes through two main pathways. One of the pathways makes leukotrienes, the other makes thromboxans and prostaglandins and prostacyclines. Here, phospholipase is responsible enzyme for conversion of membrane phospholipids into arachidonic acid, and further arachidonic acid is converted into thromboxans, prostaglandins, and prostacyclines by the help of Cox enzymes. Now here, corticosteroids, they inhibit phospholipase, and NSAIDs, they inhibit Cox enzymes. So this, however, the mechanism of action, the summary, the schematic diagram.